I would like to thank Dr. Sudipto, Dr. Garg, and the entire organizing team. And I'm going to talk the role of ductal and the anatomical anomalies in recurrent acute pancreatitis, pancreatic divisum, and beyond. For next 12 to 13 minutes, I'm going to talk what is recurrent acute pancreatitis. I think this definition has been already cleared by my previous speaker. What are the type of anatomical and ductal anomalies? Pathogenesis of pancreatitis with different ductal anomalies, and what is the role of endotherapy? I think that the last part is more important. What is the role of endotherapy in ductal anomalies? So the definition is two or more distinct episodes of acute pancreatitis with the well-documented separate event at least 3 months apart, with a complete resolution in between episode and no evidence of chronic pancreatitis. So that is a definition of recurrent acute pancreatitis. A sentinel episode of acute pancreatitis, roughly around 10 to 30% of the patient may develop the recurrent acute pancreatitis, and around 1/3 land up into a chronic pancreatitis. So if we rule out non-alcohol and non-biliary causes, then the other common causes of recurrent pancreatitis, again discussed by previous speaker, alcohol. And the occult gallstone, it is very important for the students to understand. This is many of the time wrongly interpreted in the form of microcrystal sludge and microlithiasis. It is important for you to understand what is microlithiasis and what is the natural history of microlithiasis. It's not the topic of this talk, but this is important because this is interchangeably used by many of the gastroenterologists while doing endoscopic ultrasound. Occult malignancy should always be think in an elderly patient when comes with the recurrent pancreatitis, a genetic mutation in the young patient where there is no alcohol, no stone, and other like metabolic hypertriglyceridemia, hypercalcemia, autoimmune, which is very uncommon cause of recurrent pancreatitis, but type 2 may sometimes be associated. And I'm going to discuss the anatomical anomalies, that is APBJ, pancreatic divisum, ANSA pancreatica. Annular pancreas is not the common cause. Main presentation is gastric outlet obstruction, meandering main pancreatic duct. So before that, it is important to understand what is the embryology of pancreas. Roughly around 7th week of gestation, there is a ventral duct, and it clockwise rotate and combined or join with the dorsal duct. And the ventral duct form the uncinate process, the dorsal duct form the neck, body, and the tail of the pancreas. And any problem at that stage lead to the ductal anomaly. And meandering main pancreatic duct means either the pancreatic duct is jet shaped or there is a loop formation, but the secretion is through the duct of Wurzel. In ANSA pancreaticus, there is a loop which join the main pancreatic duct, then there is a loop and it go to the minor pancreatic duct. That is ANSA pancreaticus, and etiology of recurrent pancreatitis is reflux of pancreatic juice. APBJ, the commonly there is a long channel, and it is type 1-2C, Comey type, that is between the CBD and the pancreatic duct, there is an acute angle of roughly around 90, and Comey type 2, that angle is less, and in Comey type 3, there is a multiple connections, and main mechanism of pancreatitis is bile reflux. Centronocele, I think it is important, where there is a cystic dilatation of the dorsal pancreatic duct. It may or may not be associated with the pancreatic divisum. That is important, and this is the cause of recurrent pancreatitis by obstructive pancreatopathy. There is a bulbous dilatation of the intraduodenal portion of the pancreatic duct. So I think the pancreatic divisum we commonly see in our day-to-day practice is most common anatomical anomaly, and it results from the failed dorsal and the ventral fusion of the ducts, and that lead to a preferential drainage of pancreatic juice through the duct of Santorini or the minor papilla, and it produces obstructive pancreatopathy that lead to the recurrent pancreatitis. The prevalence in the general population is around 8%, but majority of these patients are asymptomatic. The question comes, is pancreatic divism as a soul of recurrent pancreatitis or not? So this is the question, is it a cause of recurrent pancreatitis? And if it is, does endotherapy going to help doing the minor papilla sphincterotomy or not? This is the main topic of my talk. So there's a three kinds of pancreatic divism, type 1 and type 2. There is a absent dorsal and ventral communication. In type 3, there is a filamentous communication between the dorsal and the ventral duct. Now, where is the controversy lies? Because there are studies which talk that in more than 2/3 of the patient, sphincterotomy work, and the latest trial talk about it doesn't work. So if the hypothesis that the pancreatic divism causes recurrent acute pancreatitis because of obstructive pancreatopathy, then these things should be visible, meaning that the prevalence of pancreatic divism should be greater in the patient of idiopathic pancreatitis than general population. Here you see 8% in general population, 8% in patient with the recurrent pancreatitis. The dilated dorsal system should be present in the patient of recurrent acute pancreatitis and pancreatic divism if there is a functionally significant obstruction of the dorsal duct. So that is not seen always in these patients. Pathological changes should only develop in the dorsal duct mainly because there is a compromised dorsal duct, and the frequency or severity of recurrent attack of idiopathic pancreatitis should diminish with the drainage of procedure, that is by doing the minor pancreatic papillotomy. But that is not there. So if you look at the pancreatic divism prevalence in the general population, this is a D-Mango study. In 23 autopsy studies, 41 ERCP, 13 MRCP, and the prevalence of pancreatic divism in idiopathic pancreatitis and general population is same. Now this is the study from All India Institute from Professor Garg, and what they have shown that patient who has healthy control in comparison to patient of pancreatitis, the SPINK mutation or CFTR polymorphism is more in comparison to healthy individual, and with or without pancreatic divism, this incidence remains same, meaning that patient has a recurrent pancreatitis with pancreatic divism or without pancreatic divism, incidence of this genetic mutation remains same. Another study by Burton, and what he has said that PD may not be the cause of pancreatic divism, may not be the cause of pancreatitis. What they have seen, patient who has a idiopathic pancreatitis or no pancreatic disease, what they have seen, patient who has a mutation, either SPINK or CFTR or PRESS, the pancreatic divism is more common in patient who has this mutation in comparison to rest of the population. So almost half of the patient of pancreatic divism should have a thicker pancreatic juice, and by doing the pancreatic papillotomy, minor papilla, it might benefit. But both the studies don't talk about the natural history of pancreatic divism. These are the two studies which talk about natural history of pancreatic divism. That is 40 patients with the heavy alcohol and CCP, 20 with the no pancreatic divism, 20 who has pancreatic divism. And what they have seen that there is no difference in the age of onset of disease or exocrine endocrine insufficiency or frequency of acute and chronic pancreatitis. Meaning that these patients, when they followed up, there was no difference between patient who has associated pancreatic divism or not. The second study, 87 patient, again 30 with the pancreatic divism and 57 without pancreatic divism, and what they have seen that isolated dorsal duct disease occur in the equal frequency irrespective of pancreatic divism. So meaning that it is not the sole factor, it may be a bystander pancreatic divism. Now let's talk about the endotherapy in these patients. And if you look at the data, more than 13 papers in 328 patients. And from these 13 studies, there's a two meta-analysis. One was recently published in 2024. And that shows that if you do a minor papilla sphincterotomy, the pooled success rate is seen in around 67 to 70% of these patients. And the clinical success, no further episode of pancreatitis, reduction in the pancreatitis, and better quality of life. And no further pancreatitis seen in around 60 to 65 to 70% of these patients. But the problem with this study was They are either a single center or there is a variable definition of clinical success and lack of blending with the non-interventional group. And the people they have done, they just see that how much patient they are going to benefit, and they see that around 2/3 of these patients are going to benefit with the minor papilla sphincterotomy. So what is the proponent that how doing the minor papilla sphincterotomy have that potential to alter the natural history, eliminate the number and frequency of episode, may alter the severity of disease, but the downside is if it is not going to change anything, then risk of inducing a new pancreatitis handling the minor papilla may be seen in 10 to 15% of cases, stent-induced injury and the sphincter restenosis. So do these patients really require ERCP? And for that, I think this is a one randomized controlled trial, that is the blinded randomized sham controlled trial, that is ERCP plus minor papilla sphincterotomy versus sham ERCP. And the primary outcome was acute pancreatitis after 30 days of randomization, and the secondary outcome was the incidence of chronic pancreatitis, diabetes, exocrine pancreatic insufficiency, and patient-reported outcome. They were planned to do, I think, around 180 patients, but end up doing 146 because of the cost constraint. And what they have seen that the rate of acute pancreatitis and time of acute pancreatitis was not different in the sham group as well as in the patient who did the minor papilla sphincterotomy. And it was not statistically significant. So either they do sphincterotomy or not, there's no change in the rate of pancreatitis in both the groups as well as the incidence of pancreatitis. And when they did the subgroup analysis, what they found that the rate was not different in the different age group, in a patient of the different sex, patient with associated diabetes or alcohol use, and even patient who has a dilated duct or central seal. But the problem was number of patients with the dilated ducts and the central seal was very less. And among the secondary outcome, the incidence of chronic pancreatitis, the incidence of diabetes mellitus, exocrine insufficiency, there was no difference between the sham group and patient who underwent minor papilla sphincterotomy. When you look at the safety parameter, there is a difference in terms of acute pancreatitis within 30 days, although it was not statistically different, but I personally feel, I'm not a statistician, but if they would have completed this data to 180, then there is a possibility the post-procedure pancreatitis would have been more in the sphincterotomy group in comparison to the sham group. So the conclusion of this sharp trial was ERCP in patient with pancreatic divisum and acute pancreatitis may not be helpful at all. But the rebuttal, the thought process is, should none of the patient with recurrent acute pancreatitis with pancreatic divisum undergo minor papilla papillotomy? I think so. It's not right. It requires more studies and more RCT to prove that, because a dilated dorsal duct or patient who has a central seal may be going to benefit by doing the minor papilla sphincterotomy. And frequency of genetic mutation in each group was not discussed. It is unclear whether the patient were tested or not. I think I was listening to the DDW paper they have done, but they are doing the genetic analysis, but they have not at least come out with the paper. The question is, should patient with the CFTR mutation or SPINK mutation undergo a sphincterotomy because juice is thicker and it helps in flowing of the pancreatic juice better? When we talk about the ERCP in other ductal anomaly, I feel as like pancreatic divisum, same other ductal anomaly might behave, but the data is so sparse to say confidently that doing the minor papilla sphincterotomy under other disease like ansa pancreatica or the mentoring pancreatic duct or APBJ. But I feel again, in 2/3 of these patients, the small paper that shows doing the minor papilla papillotomy is going to benefit. But theoretically, I feel that patient who has a dilated dorsal duct, patient who has a stricture in the dorsal duct with the pancreatic divisum, patient who has a central seal, or patient with APBJ, especially type 3, might be going to benefit with the ERCP. So to summarize, the anatomical and the ductal anomalies of the pancreas are not common, or we don't know the exact prevalence for the cause of recurrent acute pancreatitis. The mechanism of RAP in these anomalies could be because of obstructive pancreatopathy, bile reflux, or pancreatic juice reflux. Pancreatitism is most common ductal anomaly, and the genetic mutation are common in patient with pancreatic divism. ERCP is not helpful in all cases of PD with the recurrent acute pancreatitis, but may be helpful in a subset of patient, and that require further study. Thank you for patience hearing. And with that, I invite you for our upcoming India-US Summit. There is a very good hands-on program. Those who are interested, please register for this. Thank you.